So, dear colleagues, friends, so I see you are very tired. It's not so much people here anymore, but it was also interesting also to be away from my speech. So what you have seen is we have performed a Femto-Presby-LASIK performance, and you have to take a look to assess this procedure. We use femtosecond laser, the LDV, for cutting the flap. And SuperCore is our procedure algorithm for presbyopic, which is designed for hyperopia, myopia, and also ametropic eyes. So what we begin with the hyperopic patients study, myopic we will show in the near future. We have also taken a series of patients. So for the SuperCore we utilize it's important having a full rotations eye tracker system, not only for Y axis but also for the rotational axis. Important is the K and Q value, and so we make a clinical study. What is important, what I want to show is we create with the Femto-LASIK, with the SuperCore and spherical ablation. So we perform this procedure, customize, and we correct this procedure with wavefront guided correction. So we have a bigger range of addition of the SuperCore control. So that's the point. What we do? We correct first for the far and doesn't work. Okay. For the far, we make the correction with hyperopic, myopic, and then in the 3 mm zone, we perform then the addition for near. Which patients we have taken? We have patients from 0.5 to 4 plus 4 dioptries with an astigmatism of 4 dioptries. So each patient have had a minimum visual acuity of 0.8. So the angle kappa should be less than 2 dioptries, and the near addition should be a minimum plus 2. And each patient should be minimum 50 years old for this study. It's not blue screen, but okay, we can shift to the second view. Okay. What we have seen in the hyperopic patients like this, because we correct the hyperopia, so the shifts in the first postoperative day lead to a minus. So the target refraction postoperatively is minus 0.5. And okay. Let's see. Yes, we come to the results. It's too risky to perform to show the video again. Oh.
Continue with the other one, without the full screen.
Okay, okay. Now, why don't we full screen, please? Where's the presentation? Okay, so what we have seen is that the visual acuity increases. The near visual acuity increases very fast at interlocular visits to 0 and remains very stable for the year. That's the goal for the hyperopic patient. So we gained very fast the visual acuity for near, but we apply a little bit faster. But it's important to explain to the patient that the whole hearing time is half a year. So you have shifts, one for near, one for far. So this range is each month smaller and remains stable after 6 months. Okay, let's go on. So the result for intermediate visus is a little bit needs a little bit more time. That's the computer visus, that the patient has also the possibility to have the sight without glasses, with spectacles. What it needs anyway 1 week, and then it shifts more and more to a visual acuity of 0.8 to 1.0, and it remains also stable for the intermediate setting. Now, it's very important to explain the patient. Really, this 6 months is a long period that they have to wait, that the far vision is stable. So you see that at the first day, the near vision is good, the far vision is not so good, and they have even wait for driving the car maybe up to a week that you have a visual acuity which is enough. And explain them that the visual acuity increases at the end it will be at a level of 0.8 at 1.0. Okay, let's go. Over the time diffraction, we see that the effect of the hyperopia correction, and then it shifts slowly to 0.5 and remains after 6 months stable. Also, the uncorrected visual acuity for distance, it's better visual acuity for binocular, but what we perform, we make a slightly monovision. This difference between the eyes is difference of 0.5 diopters. For the near, we have very fast the correction, and the patients are normally very satisfied already at the first day that they can read without correction. So let's go to the case report. I have something special for the Presbymania. You have a patient which has corneal enhancer following radial keratotomy. It's 20 years ago. Now this generation shifts to a presbyopia. And so we tried out to perform this procedure. So I will show this video. We cut with femtosecond laser, with LDV, it's femtosecond laser. You see here the radial resection. You will see that afterwards better. So it is a little bit more difficult to separate forever at the scar level the flap, but it remains stable. Make it slowly, but the epithelium keep it together. So we have a real good cut. And you see here the radial keratotomy. And the patient shifts in a hyperopia during 10, 12, 20 years. Then we perform this procedure as usual. We tried out the same nomogram because we didn't know what happens with the scar. But it works very well in this patient's eye, so we have the nomogram, it was perfect. You see that? Here you see it very well now, the cuts in the 3 mm zone. And but we never know what happens with the addition, because the addition is just in the scar area, if it's enough for the addition. Let's go to the results. So, it is normal. At the first day, the visual acuity increases. It doesn't increase, it remains the same as before the surgery, at 0.3. But after 1 week, one eye was already at 0.8 and the other 0.6. So this woman has, during 20 years, a visual acuity of 0.4, and it was satisfied. For 3 years now, a new life have a visual acuity of 0.8. And afterwards it remains stable. So for these patients, we have a radial keratotomy. It needs more time to solve the visual acuity. The uncorrected near visual acuity was also very well. However, they have already in the first day increasing at 0.4, and already at first week we have one eye of 1.0. And this remains stable. So one eye at 0.8 and the other at 0.1. That's the relative monovision will be done with a difference of 0.8 correction difference. Come to the conclusion. In comparison of near and distance uncorrected binocular visual acuity, the supracorneal treatment results in excellent improvement. However, for the near vision, and a very good vision for the distance. Thank you for your attention.
Thank you very much, Bojan. Any question in the audience?
Pani widziałem przykład poważny for myopic patient.
For the myoptic patients, it's just a little bit different. For the myoptic patients, the far vision is quite better. If you start with -5, 6, but there is mandatory that you perform this difference of a half dioptry and have a bigger range for the near. But the near is then lower than the far, and it's a completely different way to have out. But at the end, they are the same.